the Pelargo study, as it's called, is a large global study, which is a phase 3 trial, which compares a standard chemotherapy regimen, which is R-GemOx, which is rituximab, gemcitabine, oxaliplatinum. And the comparator arm is R-GemOx with polatuzumab vedotin, which is an antibody-drug conjugate, which is now approved for diffuse large B-cell lymphoma. So the purpose of this study is to demonstrate or test whether the introduction of this antibody-drug conjugate improves the outcomes of patients with diffuse large B-cell lymphoma treated with R-GemOx in the relapsed refractory setting. And this trial is still ongoing, but I think there's a fair amount of optimism that we may see a positive result here, which would improve or expand the number of treatment options for patients with relapsed or refractory diffuse large B-cell lymphoma.
I think that the 80% plus of patients had at least 2 lines of therapy, and 2/3 of them were refractory to the last regimen. And the trial was reported, I don't remember the exact number of patients, but the trial was reported with a metabolic response rate, overall metabolic response rate at the end of treatment of 24% and then 18% complete metabolic response. It's early for the follow-up, but this is again one of these combination of biological agent plus immunotherapy that might bring an opportunity to the unmet need of patients who are not eligible for high-dose therapy, transplant, or potentially CAR T cells. Another example of the impact of immunotherapy as well. This is a very exciting time in the field of medicine, particularly in lymphoma as well, where we have been for decades doing the R-CHOP and then remain as a standard of care default. But we definitely should be aware that this is not sufficient in a high-risk IPI patient, double hit, double expressor, and non-GC subtype and other high-grade lymphoma that I alluded to previously. And I think that these patients should be great candidates for clinical trials and probably more intensive therapy and maybe cell therapy consolidation like the ZUMA-6, looking at a CAR T as a consolidation in patients who are double hit lymphoma, high-grade lymphomas. The question of p53 is really not answered, probably underestimated. But the future is really the classification of lymphoma is to continue the biological classification and try to identify, to improve this curve that we see, to identify truly the high grade. And in order to do this, we need to have baseline signature that is usable in routine and actionable. And I think cell-free DNA or circulating tumor DNA is likely to be more usable and used in the future. As I mentioned, immunotherapy more and more part of the induction or pre-phase window or consolidation. And again, given all the opportunities that I just mentioned tonight, it reflects on the fact that this is really important to encourage patients to go on clinical trials and colleagues to participate. The reason being is that when you look, we see large cell lymphoma being, the impression large cell lymphoma now is all quote-unquote resolved, the outcome is so great, but when you look at real world data in high-risk patients, the outcome, particularly in a high-risk patient, is still very poor. So I would encourage really to look at clinical trials in this population as well. Thank you.